से फेलोशिप शुरू किया है। जब से हमने फेलोशिप शुरू किया माशाल्लाह वी हैव गॉट a good number of young vascular surgeons which is an excellent thing। और फिर जब आपके एफर्ट्स के आप उस टाइम पर कहते हैं you continuously try to teach everybody and that's commendable। So let's start vasculitis। I mean, I will be very casual. I won't be. It's not so formal type of presentation। इसको ऐसे चिट चैट करेंगे। And just to let you know, I graduated from Doha Medical College very very long time ago। That was in 87। And I trained in the UK. I worked in the UK as a consultant। 2015 I left and went to Saudi Arabia and then to now in UAE। So that is my background। So I've been involved with for teaching for some time now, alhamdulillah। So let's start। Vasculitis is a very, I would say, not a surgical disease। आप vasculitis का although we are the first point of contact to get these patients, but surgically we hardly do anything for vasculitis। And we normally our aim is to just assess the patient and refer them to appropriate specialty, and which is usually a vascular medicine, जो कि Dr. Noor, he hasn't joined us yet। So Dr. Noor is a professor of vascular medicine। तो अगर आपके डिपार्टमेंट में vascular medicine का कोई आदमी है तो you refer to them, or you refer it to the rheumatologist, which is usually present in every specialty। और one-liner here है, I would say the one-liner in vasculitis is that vasculitis आपके पास अगर आए कोई, so just assess the patient and refer them to a rheumatologist and you are done। But I think from the point of view of learning, we need to know what vasculitis is, what does it involve, how it can affect and things like that। तो उसके लिए फिर हम ये आपको एक छोटी presentation दे रहा हूँ। And let's see, and I will not go into details of each and every disease। I will actually touch on a few important ones जो कि हम usually सुनते हैं, but I won't go into much details for that because I think you need to know about it, but you don't need to go into detail। Okay, next slide। So how do you define vasculitis? Vasculitis is a spectrum of disorders characterized by acute and chronic inflammation and inflammatory changes in the vessel wall। We can also define it as a group of disorders that result in the inflammation and necrosis of the blood vessels, with subsequent impairment of the blood flow resulting in ischemia or infarction of the distal tissues। It can be the hands, it can be feet, it can be other end organs। So this is what you patients come across with। So if it's a problem in the lower limb, patient will come to you with intermittent claudication or maybe a gangrene or maybe some other lesions। So you need to know what you're dealing with। How do you classify them? I have classified them very simply, and this is, I think, is the best classification, although there are other classifications as well। I have kept it very, very simple, and I think that is very important in vasculitis to understand and have a good understanding of this problem। One of the commonest and the easiest classification is the size of the arteries which are involved in the process। So it can be the aorta or its branches, it can be large or medium-sized vessels, it can be the medium, small-sized vessels, small vessels, or even in the vascular bed, like the capillary bed, microvascular occlusion. And I've written a few diseases under each one of them. Like Takayasu, you have heard about it. You have got a lot of Burgess disease. You have heard about giant cell arteritis, and when the medical colleagues ask you to do a temporal artery biopsy, and you say, why they are asking for temporal artery biopsy? So we'll look into that and why that is important, and what can be the outcome if giant cell arteritis is not treated. मीडियम एंड स्मॉल साइज में फिर वो बर्जेस भी आ जाती है, वो क्योंकि वो बिलो द नी वेसल्स को या मीडियम साइज वेसल्स को इन्वॉल्व करती है, जाइंट सेल आर्थराइटिस भी करता है. And then very important one is the polyarthritis nodosa. You may or may not have come across such a patient, but you will come across it in the literature, the polyarthritis nodosa. So इसलिए it is important. Then the medium-sized vessels may be excuse me. The medium-sized vessels में polyarthritis होता है, but Wegener's granulomatosis, इसका नाम वैसे चेंज हो गया, but Wegener's granulomatosis, I think that is also a medium size, but not as common. जो small vessels में भी होता है, you come across connective tissue disorders, you come across rheumatoid vasculitis. All the rheumatologists keep sending to your patients with vasculitis due to rheumatoid. So all these things, and then when you come to the capillary bed, the vasculitis or arteritis or vasculitis, it actually extends from the arterial end of the capillary bed to the venous end of the capillary bed as well. So the diagram below shows you all these different, types of the vascular bed and the arteries the arteries involved and the type of vasculitis. And as you can see, the Behçet's disease involves all the way from the aorta to the IVC. So I will touch that as well. How do these patients present? I mean, as I said, majority of these patients come to you just by chance, or they are sent to you because they say, oh, it is all a vascular problem. But there is no single presentation in vasculitis. Patients come with ischemia, patients come with skin changes, patients come with gangrene, with ulcers, with like marble type of skin changes. So अगर large vessels involved होती हैं, large vessel vasculitis often presents with lymph claudication, vascular bruise, asymptomatic blood pressure in both hands, both arms, absence of pulses, and medium-sized vessels के अंदर cutaneous nodules and ulcers, levator reticularis. This is what levator reticularis looks like, that marble-like appearance on the skin. With the capillaries, and हम कहते हैं यार ये पता नहीं क्या है. I mean, we don't make anything of it. ये इन पेशेंट्स को हम कहते हैं या कुछ सर्दी की वजह से हो जाता है या किसी और वजह से हो जाता है, which probably is, but I think you have to keep this in mind, that levator reticularis is a very important presentation sign of a few of the vasculitis, like polyarthritis or other things. So we will come to that later. Digital gangrene, we have already mentioned. Mononeuritis multiplex. Again, mononeuritis multiplex, what happens is a vasculitis of the vasa vasorum. And that causes occlusion, and that causes ischemia of the nerve, and then mononeuritis. Then renovascular hypertension. renal vessels are involved, and the patient gets hypertension because of the renal artery stenosis. And this is again is a very common in polyarteritis. Small vessel vasculitis tend to present with palpable pupils. The skin changes. There's a lot of overlap between the dermatologists and the rheumatologists and the vascular surgeons because these patients rotate between these three specialities. So palpable purpura, as I said, pulmonary renal syndrome, glomerulonephritis, or alveolar hemorrhages, then arterial skin rashes हो सकते हैं, and scleritis हो सकता है. So all these things, and as you can see this one, there are a lot of skin changes which patients come with, and then there is a little bit of ischemia as well. You may find that you can feel a pulse, but why is the patient getting all these changes in his foot or in his in the skin? We don't know. And obviously, Berger's, patient comes with Berger's and who all the vessels, small to medium and small vessels are all, vasculitic. And patient has already had digital ischemia and had amputations and developed more ulcers. And so these are the things which these patients present. Now, histologically, what do you mean by vasculitis histologically? So, all these vasculitis or vascular tides typically cause characteristic histological features. There's infiltration of the vessel wall with neutrophils, with mononuclear cells, and giant cells. There is fibrinoid necrosis with pan-mural, the mural destruction of the vessel wall. Now, this is leukocytoclasis is one word. I have actually broken it into three just to how to pronounce it and just to remember it. So leuko and cyto is white cells, yeah, and clasis is destruction or disruption, whatever you can say. So leukocytoclasis is a histological feature in vasculitis where the leukocytes are disrupted, resulting in histological finding. What they call is the nuclear dust. I'm not sure about it. I don't know what dust look like under the microscope, but this is what is documented that patients look at nuclear dust, which is a histological diagnostic feature of vasculitis. So there is also, obviously, like anywhere else where the inflammation is the perivascular infiltration perivascular infiltration alone in a non-specific histological finding, which is not diagnostic of vasculitis. So you can find perivascular infiltration, but perivascular infiltration on its own, without any thrombosis, without any infiltration of the cells into the wall, is not a diagnostic of vasculitis. So it is important for a histological feature that the wall of the artery is also involved with inflammation, not only the perivascular tissue. Now, as we know that the inflammation is can be cell mediated, it can be immune complex mediated, it can be humoral, it can be so all these things are involved in the histological in vasculitis as well, and but it depends upon which arteries are involved. Like large arteries, giants for the giants like arthritis, Takayasu, so all these are cell-mediated inflammations. Whereas polyarthritis nodosa, cryoglobulinemia, and other angiitis, these are immune complex mediated. So ANCA-associated vasculitis involves both cellular and humoral immune responses. So, you have to keep that in mind. In your exams, when you're answering the questions, you have to keep that in mind that these arteries are also an organ, and these arteries can have inflammation similar to other parts like a humoral, humoral or cell mediated, or so these are the things which you need to keep in mind. So, if a patient comes with, I've just taken it from an article. Um, uh, Very simple, I think it is given, so that's why I brought it up. Patient comes in with vasculitis. You suspect vasculitis with. So, how do you go about, working it up? So, you suspect vasculitis. First of all, you rule out macrovascular disease. तो आप जो अपनी वैस्कुलर डिजीजेस है यानी कि पेरिफेरल आर्टरी डिजीज या एथरोस्क्लेरोसिस और अदर चीज तो you just need to excuse me you just need to rule out those. You do the ABPI, you do the imaging, whatever imaging you want. You do the duplex scan, the CT scan, your digital waveform analysis, you do chest X-ray. All these things. And also, very important is cervical rib or TOS. कि ये patients जो हैं sometimes present with changes in the hand, and you're not sure that it is TOS or it is just something else going on. So you have to rule out all these things. So vasculitis is mainly ruling out all other known causes of the problem, and then you come to a conclusion. So it is a diagnosis of exclusion. But there are certain tests as well. When you have excluded main things, then you come up to other things. So उसमें हम बेसिक इन्वेस्टिगेशन सब करेंगे जो हम नॉर्मली करते हैं, फुल ब्लड काउंट, यूएनई, एलएफटी, जो ये सारी मैंने यहाँ पे लिखी हुई हैं. एंड देन you have to do also the एंड ऑर्गन सिम्टम्स. आप उसका चेक करें, मेक श्योर दैट उसको कोई ऐसी और वजह नहीं है, यानी कि आप उसके जीआई को चेक करें, उसके livers को चेक करें. All these things need to be looked at. So why the patient would have constitution symptoms of fever, malaise, arthralgia, ये सब चीजें जो है need to check. Is there any evidence of systemic or cutaneous involvement? And that is very, very important. In vasculitis, the cutaneous involvement is very common. And also non-specific symptoms. For example, pyrexia of unknown origin. Patient कहता है कि I have मुझे बुखार हो जाता है डॉक्टर साहब, मगर वो फिर अपने आप ठीक भी हो जाता है, कभी होता है, कभी हल्का सा बुखार रहता है, हर वक्त रहता है मुझे बुखार. So all these things, when you have actually looked into all the known causes of arterial problems, and you cannot find any pinpoint अब चीज ठीक है, and then you have to exclude कर दिया आपने common causes, then you come to a very, it's a jigsaw that patient को स्किन चेंजेस है नहीं है, उसको कॉन्स्टिट्यूशन सिम्टम्स है नहीं है, वो आर्थ्रल्जिया है, मलेज है कि नहीं है, वेट लॉस तो नहीं हुआ, माइल्जिया तो नहीं है, CRP ESR रेज है कि नहीं है. So all these things then fits in together, and then you say, yes, these are the patient has constitutional symptoms as well, or the cutaneous involvement, then it is likely to be vasculitis. Then you do all the autoimmune antibodies. तो उसके अंदर आपको एंटी न्यूक्लियर एंटीबॉडीज भी हैं, और PN का भी है, CN का भी है, और rheumatoid factor भी है, antiphospholipids, and all these things, cryoglobins. So these are the things which I normally just simply send it to the rheumatologist and say, I have excluded. Now it's your turn to investigate and find out as to what is the cause. But this is how we go about it. And then अगर positive आते हैं तो how do you correlate with the clinical findings? अगर doubt हो तो biopsy is the last thing you do. You don't jump onto biopsy very, very quickly. और अगर negative है So then again, you might have to do a biopsy. Otherwise, rule out all the causes. Whether you have endocarditis, TOS, infection, cutaneous vasculitis. So all these things, malignancies, sometimes they present with very, unusual presentation. अगर इन्वॉल्वमेंट इसकी एविडेंस जो है नहीं है of the systemic or cutaneous involvement, then you should look into any vasospastic symptoms. तो वो है कि नहीं है. So अगर नहीं है तो probably benign. अगर है so you need to go into the rheumatoid, check the changes in the hand, the Raynaud's, rheumatoid, primary and secondary Raynaud's, all these things you need to look into. So I thought that it is a very simple and comprehensive type of an algorithm, which one can keep in mind, and how to go about to investigate this patient. So these are some antibodies with antibody tests with the type of diseases where they are positive or negative. I won't go into details for that, but just for your academic point of view, have a look at it. The antiphospholipid, tachycardiolipin, ANCAs, all these things. Now I'll go on to a few specific diseases. Or I've recently seen a couple of patients, and I will discuss that in the end. But I couldn't upload their images or things, but I will give you a verbal, how do they present and what is the situation. Any questions up till now?
Yeah, that is excellent presentation actually, and taken the core aspect of that. So, my is, for example, a patient comes. How early one should involve the rheumatologist in the decision making or anything else? At the very start, or should give the initial investigation. For example, a patient come with a suspected vasculitis to a vascular clinic. So when should one involve the rheumatologist or medical specialist in it?
Yeah, actually, my approach is that if you have a facility, for example, if I'm working with Dr. Noor, for example, or a vascular medicine colleague, then I will have a very, I will see this patient once, and I will rule out any major vascular issues. And then I will, if I suspect vasculitis, I would simply pick up a phone and tell him that this is the patient and that is it, and I will refer it to him. And or a rheumatologist who is interested in vasculitis, because some other rheumatologists are not interested in vasculitis. If you have that facility, then use it. And the more you use it, the more you will find that you will be able to diagnose the vasculitis early, and you will be able to have a good rapport and communication with them. But if you don't have that facility, then you will have to do all these things, ruling it out on your own. And that is very, very important to understand. Yes, I have said in the beginning कि जी आप उसको फौरन भेज दें, but on the other hand, these patients suffer a lot if we don't diagnose them. Although the treatment is all medical, and occasionally you have to treat them surgically, but I think you have to build up a team to see these patients. It is a multidisciplinary approach. You cannot do it on your own. But if you have a medical colleague who is interested in vasculitis, then I'll have a very the patient will be with me for a very short time.
Yeah, I will ask the participants if they have any question, and if they can raise their hand and ask any question or place it on the text. It is how it is there. So the other situation which we usually get is that there had been extensive workup done by rheumatologists and medical specialists, and they do definitely come to a vascular surgeon to rule out macrovascular or any cause which can be correctable surgically or endovascular. So therefore, the knowledge of all these entities and all these tests and the limitation of these tests is very necessary for a vascular surgeon. But practicing in Pakistan, this is very important because patient also wants an opinion from vascular surgeon and also the medical specialist and rheumatologist. Even they have done all the workup and made a diagnosis. They want to rule out any things which are not missing.
Yeah, I think this is very important
Mm.
because this is a collaboration. Because if they have already diagnosed a patient, and for example, patient has Takayasu, okay, patient has Takayasu, they have started the treatment, they have started immunosuppressing or anti-inflammatories and things, but obviously you'll have to be seen by a vascular surgeon to rule out any surgical involvement at some stage, because these patients might need involvement at some stage. So you have to be a very, you have to keep them, keep seeing them at least once a year, or just to make sure that you don't miss out on these things.
Yeah.
So it is important to have a collaboration between them.
Yeah, we can continue.
Okay, so let's talk about a few of these diseases. मैं एक दो लूंगा लार्ज वेसल से, एक दो लूंगा स्मॉल वेसल से, और उसके बाद एंड में मैं ब्रैकेट्स के बारे में बताऊंगा, जो कि ह्यूज स्पेक्ट्रम फ्रॉम आर्टरीज टू द वेन. So, Takayasu is prevalent more so in our part of the world, in Pakistan, in Asia, Southeast Asia, in Japan, in all those areas. And there's a female preponderance, and 8:1. So you can see that most of the female who present to us with this kind of problem. It is said that there are two phases of the disease. One is acute systemic phase, which is also called pulseless phase, pre-pulseless phase, sorry. And the other one is chronic obliterative phase, which is also called pulseless phase. So the non-pulseless phase or the pre-pulseless phase is very non-specific. The patient will come and have fever, can have malaise, myalgia, arthralgia, जो हमने सारी बातें कही थी, weight loss, headache, with vessel tenderness. So आप कोई arteries palpate करें तो उसको हो सकता है उसको tenderness हो उस जगह पे. So but patient has good full complement of pulses, but all these non-specific symptoms. Then it comes to a chronic phase where it becomes then obliterative, as you can have nodular thickening of the skin, you can have stenosis of the arteries, you can have fibrosis, sometimes you can get aneurysmal formation, and pulmonary arteries are involved about 50% of the cases. The hypertension is also common to the renal artery stenosis, and I will show you some pictures of that. So how do you diagnose it? Clinical pattern is very important. History is very important. That is why we as surgeons are very poor in taking histories. We don't go into proper detail or don't pick up the subtle signs which the patient tells us, and don't go into details. And one of the reasons for that is that we don't see these patients regularly, number one, and number two is we look for our the things which we do as surgeons, and we don't go into this medical detail, which is a shame. But this is how the things are. This is what happens. And nowadays, in the trainings as well, we don't insist or ask the students to learn how to take proper histories. at least in the West and in other part of the world. But anyway, so it is very important to know all these non-specific type of symptoms, and then you have to do some investigations, duplex scans, or angiography, CT angiography, and that actually then picks up all the occlusive and non-occlusive disease. Inflammation, I've already mentioned that all layers of the arteries are involved. There's a chronic granulomatous formation, granuloma formation, nodular thickening of the arteries, and medial adventitial fibrosis. But excuse me, one of the things which is important is that artery has skip lesions. It is not a continuous one. So sometimes part of the artery is involved, and then the normal artery, then a part of the artery is involved. So that is also important to keep that in mind. 15% of these patients have RH factors positive, rheumatoid factors are positive, and anti-recurrent antibodies usually are negative. So what is the treatment for Takayasu? It is all medical treatment unless it is an end organ ischemia. Anti-inflammatories you give steroids, and if it doesn't get any better, then we add immunosuppressive therapy as required. And I think this is where all our medical colleagues come in, and that we have to give them immunosuppressive therapy, which can be sometimes as bad as chemotherapy sometimes. Yeah, so it is important to understand that. Surgical treatment is for occlusive for aneurysmal disease. And one thing it is mentioned in the books, I've never treated surgically treated a Takayasu patient as such, but it is considered only when surgery is considered only when acute inflammatory component is in remission. So you don't treat them when a patient has an active inflammation. So this has become all in it is not in remission. And the target vessels is free of active inflammation. That is very, very important. So because the arteries become very fragile in the time when there is acute inflammation. So make sure that you don't operate them during that period. So a few examples. For example, my patient is typically who has a young female who has inflammation of her arch of the aorta, but has almost 50% stenosis of the left common carotid artery, all the way up to the bifurcation. And then, you can see that here the left subclavian is occluded. The right carotid is occluded. The brachycephalic, you can see the hub, and then the right. So all these things need to be looked at. If you look at this, there is multiple things. You can see this here. The left carotid is completely, very, very thin wall. Here, there's aneurysm of the left or right brachycephalic. The brachial artery is occluded here. Axillary artery is occluded here. And then you can see the same patient. You see that its infrarenal aorta is stenosed. The iliacs are stenosed. Even the superficial femoral has stenosis. So patient can have multiple lesions, but in between you can see the normal artery. Those skip lesions. The Takayasus can have different types, and I will just touch these. The type 1 only have the arch vessels which are involved. Type 2A is ascending aorta involved with the arch vessels. Type 2B is ascending and descending aorta involved with the arch vessels. 3 is only the descending aorta and the renal involvement. 4 is renal involvement, and 5 is the whole of the aorta involved with the renal involvement. I think so. This is all academic, but you need to know these things to diagnose these conditions in your patient. So it is important to know these. This is why we are discussing vasculitis. I don't think we need to go into this detail. Again, another algorithm, but you can have a quick look, but nothing major in this. So the second condition, which is which you can come across, and I'm sure each one of you would have been asked to do temporal artery biopsy. So giant cell arteritis, and giant cell arteritis is a disease of middle-aged and elderly patients. Again, female preponderance 5:1, common in smokers and with patients with atherosclerosis. As I said, that it involves large vessels, but also involves the small and medium-sized vessels. It presents with, again, non-specific symptoms, malaise, fatigue, pyrexia of unknown origin, headache, scalp tenderness. That is very, very important to have that in mind. If the patient says कि मैं यहाँ दर्द होती है बहुत और और मुझे headache होता है, or you feel that the temporal artery is very prominent or is tender, don't investigate it for giant cell arteritis, because it can have, if it is untreated, can have quite devastating consequences. It is sudden onset, irreversible. It can cause sudden onset and irreversible blindness, as I just said, as the most serious complications. That is why it is important to have this in mind when you are treating some patients who have any tenderness of the temporal area. And patients also can have jaw claudication. खाना खा रहे हैं और उनको दर्द हो रही है, उनके मसल्स में दर्द हो रही है. That is also a sign of giant cell arteritis, and about 50% of the patients do have this. How do you diagnose this? Again, like other vasculitis, it is a clinical presentation. Plus, ESR is very raised in it, and more than 100. Duplex may demonstrate characteristic halo sign of the temporal artery. If you do a temporal artery, there's a yellow sign of the excuse me on the duplex scan. And the gold standard obviously is histological, जिसके लिए हमें मेडिसिन वाले कहते हैं कि ये temporal artery biopsy करते हैं. But unfortunately, the skip lesions as well in that part of the artery. So if you take a biopsy and you take the biopsy is normal, you may have actually taken out the artery which did not have arthritis in that portion. But that doesn't mean that the patient should not be treated. I think that is very, very important. Steroids is a mainstay of treatment. Anti-inflammatory and anti-immunosuppressive medications are indicated. This is the most important line, that when suspected, treatment should be started empirically, even before the biopsy result is available. You can this is why when the medicine वाले कहते हैं ना कि temporal biopsy करें, हम कहते हैं अच्छा यार कर देंगे, लिस्ट पे कर देंगे. No, it has to be done as an emergency, so that they can start the treatment if they haven't started it yet, or because of the high risk of blindness. And this is what it looks like sometimes. I mean, I have seen patients with the temporal artery, very tender and very prominent, patient have headaches, and sometimes you remove this, and then you find out that it is normal. But that doesn't mean that patient cannot have giant cell arthritis. And this is a halo sign on the duplex scan. There is, which is said to be a diagnostic sign for temporal artery, sorry, temporal arteritis. And then histologically, this is a lumen, remaining lumen. The artery is filled with the giant cells, the leukocytes, and the internal aspect lamina is also very, you can see that the inflammatory cells are involved there. Okay, the next one is thromboangiitis obliterans Burgess disease. I'm sure each one of you have seen patients with Burgess disease. Pakistan में और इस इलाके में, Southeast Asia में, it is very common. And it also causes vasculitis, the medium and small size vessels. Upper limb भी involvement होती है, but 95% it is a lower limb involvement, and the tibial, the below the knee vessels are involved. Patients usually present with foot claudication, not calf claudication. This is why it is important. The history is important. You ask the patient कि claudicate वो कहाँ कर रहा है, कौन से मसल्स कर रहे हैं, थाई कर रहा है, बटक कर रहा है, calf कर रहा है, foot कर रहा है. So these patients typically have a foot claudication with absent pedal pulses, yeah, and preserved femoral and popliteal pulses, and may progress to rest pain, which may इसलिए मैं कह रहा हूँ कि if the patient stops smoking and all these things, but majority of them I have come across, they continue to smoke, they don't give up smoking and end up losing their legs. It's a strong association with rheumatoid phenomena and superficial migratory thrombophlebitis. पता लगा कि उनको जो है बेटालिक वेन के अंदर थ्रोम्बोफ्लेबाइटिस हो गया या cephalic vein thrombophlebitis हो गया, but they do get thrombophlebitis as well. They are young, they are smokers. And it has a very characteristic angiographic pattern, or angiography होती है. So I think I'm sure somebody in the exams may show you an angiogram of a Burgess disease patient, and it is very characteristic. So you need to know about these. Rest of the vessels are normal, but there are corkscrew type of collaterals and tortuous collaterals, which are very characteristic. Histologically, it is hypercellular thrombus in the affected vessels. And what is the treatment? The foremost treatment is smoking cessation, which is very, 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 very important. If they don't stop smoking, they lose their limbs. Agonizingly, it is very, very painful for them as well. Vasodilators, sympathectomies may or may not work. You use those things, but they may or may not work. Surgical bypass, I have done a few, and they don't normally last long because the target vessels or the digital vessels are very small, and sometimes they occlude. And as soon as you do a bypass, patients are a little bit better. They start smoking again and back to the normal. So this is a typical, you can see that all these corkscrew type of vessels, these are the collaterals they get, but there's no named vessel in the below the knee, and this is a typical, I would say, the progress of these patients. They came with ischemia, then they came with digital gangrene, then you remove one toe, then they come with others. They get skin ulcers and all these things, and they continue to smoke, and this is what happens to the leg, and they get thrombophlebitis. And I remember reading one article in BMJ many years ago, I mean, I was, because it is a very common, um, um, I would say, uh, condition, which was used to discuss in St. Mary's in London, where I got trained. तो वहाँ पे ये very common, even the nurses, the old nurses, उनको भी याद था वो patient, that he lost all his four limbs, bilateral lower leg amputee, bilateral arm amputee, and still he actually asked somebody to make a yeah, make a holder, so it's cigarette holder, बाय वायर का जो वो होता है हैंगर, उससे उसने किसी से बनवाया, एंड दैट ही यूज्ड टू पुट दैट इन हिज आर्म, एम्पुटेटेड आर्म, और वो स्मोक कर रहा होता. So I mean, these patients are amazing. I mean, they don't give up smoking. They can lose their leg, but don't give up smoking. But this is the mainstay of their treatment: stop smoking. Again, I won't go into the detail, but that's okay. पॉलीआर्थराइटिस बस दो चीजें और रह गई हैं. दिया हमारे पास टाइम है. Shall I continue?
Yeah, this is a great talk and very relevant and very comprehensive. I would say we should spend time on these things. These are very relevant.
Okay.
Thank you for it.
So दो चीजें, दो टॉपिक्स और हैं. एक पॉलीआर्थराइटिस नोडोसा है और दूसरा ब्रैकेट्स डिजीज है. तो I will go through that
Sure. Thank you.
quickly, and then we can talk about. So polyarthritis nodosa is a disease of middle-aged male patients. Male is twice as many as female, and affects small and medium-sized arteries. And it is very relevant for Pakistan because it is a strong association with hepatitis B infection. So keep that in mind, because patients who have hepatitis B infection in the past, or still are seropositive, you have to keep an eye on them, because they can come with non-specific symptoms, and other kind of symptoms we'll just discuss, and you have to investigate them for polyarthritis nodosa. There are two recognized subtypes of polyarthritis nodosa. One is cutaneous polyarthritis nodosa, and there's another one is a microscopic polyangiitis or polyarthritis. Okay, so what is a cutaneous polyarthritis nodosa? It affects up to about 50% of patients. It has palpable purpura and libido reticularis. आपको मैंने पिक्चर पहले दिखाई थी शुरू में कि libido reticularis जब मार्बल टाइप स्किन कलर चेंजेस होती हैं, और हम कहते हैं यार इसको सर्दी लग रही है, सर्दी की वजह से हो रहा है, इसको गर्म रखें, ये करें वो करें, इसकी मालिश करें, और वो खत्म नहीं होता. And that is vasculitis. That is due to cutaneous polyarthritis nodosa. So at least, if nothing else, one should investigate, arthritis in such conditions. Patient can come with ulceration, and patient can come with digital infarcts. The microscopic polyangiitis or polyarthritis, even in this, about half of the patients have cutaneous manifestations as well. मगर इसमें ज़्यादातर जो है, the other half can have both or systemic manifestation. So again, as in other vasculitis, non-specific symptoms: malaise, weight loss, pyrexia, and organ involvement because of the necrotizing vasculitis includes renal arteries are involved in about 70% of these patients. Patient can have hypertension, patient can have glomerulonephritis, patient can have kidney failure, they have a proteinuria, progressive renal failure. So all these things, kidneys are affected in the majority of these patients. Pulmonary hemorrhages they can get. They can have micro, the arteriolar or a capillary bed microaneurysm, which can rupture and cause pulmonary hemorrhage. Gastrointestinal hemorrhage for the same very reason. Patient gets nausea, pain, nausea, vomiting, infarction of and perforation. They can have mononeuritis multiplex, as I told you, that inflammation of the vena vasorum, and can cause occlusion. And in these conditions, sometimes they can get, they can get blindness as well, because the retina can get involved, or the testes can get involved and can have impotence, or all these conditions. And they can get saccular or fusiform aneurysm formation of the medium-sized vessels. How do you diagnose it? Largely, it is again clinical pattern of again the symptom. As we said, palpable purpura, libido radicularis, digital infarcts, and all these things. And malaise, weight loss, anorexia. And they have P-ANCA levels raised. Okay. Angiography displays the arterial stenosis or the aneurysm, but the gold standard is skin biopsy. Excuse me. The gold standard is skin biopsy showing fibrinoid necrosis of the blood vessel, microaneurysm, thrombosis, and tissue infarctions. And again, treatment, unless there is any aneurysmal rupture or any other stenotic problems in the end organ ischemia, the treatment is again medical. The immunosuppression and even azathioprine. And as I said earlier, that we have to involve the medical colleagues, because if we go into immunotherapy, then sometimes the immunotherapy can be as hard for the patients as the chemotherapy. So I think it is very, very important to involve them early. So patients can present with hemorrhages and all these things. It's ulceration of the skin, nodules, and these kind of things. Now, this is very typical. I've taken it from one of the articles. Very typical. If you look at this, superior mesenteric artery, all the small end vessels, or the arteriolar level, there are aneurysms, there's a small aneurysm. You have to look into that. You have to look. You need to. Looking at these CT scans or angiograms, unless you know what you're looking at, or unless you're looking for, you will miss these very, very small dots. Similarly, in the polyarteritis in the renal, you can see that in the renal angiograms, very, very small ones, small aneurysm. These are a little bit bigger aneurysm here, but also it can also sometimes get stenosis as well. Yeah, so stenosis, aneurysm, saccular or fusiform. All these things you can get in polyarteritis into that. Batchets. Again, batchets is, as I said, as I showed you on this diagram, it's a spectrum of disease, from large arteries to the large veins. It can involve anything. So these patients come with varied symptoms, but one of the things which is very, very important is that, which we'll discuss later. Anyway, it is a multi-system recurrent systemic vasculitis affecting small vessels. That's most prevalent in Asia, Middle East communities. We do come across here in Abu Dhabi a few patients. I have come across a few patients. How do they present? They have oral and genital ulcerations. They have chronic, eye symptoms, iridocyclitis, and they can have vasculitis. And majority of them get thrombosis, the venous symptoms. So you get 90% of them have venous symptoms like DVT, unprovoked DVT, superficial thrombophlebitis, even Budd-Chiari syndrome, involvement of, although rare, but it can happen. But these patients can also have aneurysmal degeneration, obliterative endarteritis, and arthritis. So all these things can happen. And patients can also have intra-arterial, as I said, that 90% of them present with venous problem, venous DVT, unprovoked. IVC can get thrombosed. I have a patient who has thrombosed from the renal vein all the way down to his, popliteals, completely thrombosed. Similarly, and that is an young Indian chap. Then I have another patient who had unprovoked DVT in the leg, and then in the arm, and then thromboangitis. And then later came with when we investigated, she also had a huge thrombus sitting in the descending aorta, in the descending thoracic aorta, huge thrombus. And I was actually worried that this will embolize into distal vessels, but patient, these thrombi are very stuck to the vessels. Veins maybe or arteries maybe, they are quite stuck. So they are not very loose. So they usually resolve with IV heparin and anticoagulation. So, these kind of things. And if we are worried, then we can always line the aorta with a stent. But even putting, I was so afraid that I even putting a wire through this could dislodge this into any of these vessels. So it is very rare disease, and one need to keep that in mind that it can affect not only the veins, but occasionally the arteries as well. So how do you diagnose it? Largely clinical patterns again with venous involvement. Um, Arteriography may show occlusion or aneurysmal formation, but also thrombosis, thrombus formation in the large vessel. The patient I was talking about, she has a large thrombus there, and then she occluded her axillary artery as well, which was asymptomatic, but she occluded her axillary artery. So these patients and had multiple DVTs in the past, unprovoked. How do you treat them? Steroids, escalating to cytotoxic agents, immunosuppressing drugs, and then arterial disease and venous thrombosis treated as standard as we normally do. I found that interesting and with some a little bit of knowledge as well involved in this. मैंने कहा इसको मैं लगा देता हूँ just for this is my last slide. तो Behçet's disease में oral ulcers भी होते हैं, ठीक है, genital ulcers भी होते हैं, eye lesions भी होते हैं, उनको skin lesions भी आते हैं, और needle prick test उसका किया जाता है. Exaggerated inflammatory reaction होता है उसमें. When you do a needle prick test, it is an exaggerated inflammatory reaction in such patients. ये HLA B51 association होती है इसकी, और this is how they normally present these patients. And funnily, not all patients in Behçet's disease can have oral ulcers or genital ulcers or skin lesion. मेरी patient जो थी, उसके skin lesions in the sense कि उसको thrombophlebitis हो जाता था, कभी-कभी purpura है, but she didn't have any oral symptoms or genital symptoms or eye lesions, but she had multiple DVTs and thrombophlebitis, some purpura, and this large thrombus sitting in the aorta. And it is all vessel vasculitis, meaning arteries, large arteries and the large veins and everything in between. Raised inflammatory markers होते हैं. न्यूट्रोफिल्स एंड लिम्फोसाइटिक इन्फिल्ट्रेशन होती है, पेरिवैस्कुलाइटिस होता है, सूडो एन्यूरिज्म बन जाते हैं, एंडोथेलियम की स्वेलिंग की वजह से थ्रोम्बोसिस होता है वेन्स में भी और आर्टरीज में भी. तो इट इज वेरी pan vascular disease. I think we will end here. And these are all snippets for these important problems. So you know that if patients comes in with these some problem and you cannot make sense कि भाई ये क्यों हो रहा है, always think about vasculitis. So in conclusion, most commonly used classification हमने बात कर ली है कि भाई the size of the vessels के हिसाब से उसको classify करें. And majority of these vasculitides are diagnosed by the clinical signs and symptoms, inflammatory markers, and then you go on to the antibody test. But clinical history taking is very, 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 very important in these patients. Management is definitely mainly medical, steroids, immunosuppressive medications, and surgery has a very limited role. And almost patients are referred, almost all the patients are referred to the vascular clinics. So you need to know about this subject. And but important thing is its management is multidisciplinary. To have a good medical colleague, get them involved in the vasculitis, and start feeding them these kind of patients, and discuss with them so that they keep their interest alive, and that will help you in the longer term in your vascular practice. That you have a colleague who you can discuss all these difficult diagnoses with them, and this will be beneficial for the patient. Thank you.
Yeah, thank you so much, Dr. Khalid. For me, this was a fantastic talk. I really enjoyed it, and every slide was full of very relevant and pertinent knowledge related to us. So I will ask any of the participants want to any ask question, any comments, they are welcome. They can raise hand or they can voice. So one of the tasks which I wanted, if there's any no question, all participants will write name of two large vessel vasculitis, two medium-sized vasculitis, and two small vessel vasculitis in the chat box. Nasser has raised the hand. Ji Nasser,
सर
you want to ask any question?
सर मैं एक लेमैन सा क्वेश्चन है मेरा सर. ये हम जो जैसे अभी ये डिस्कस कर रहे थे वेस्कुलाइटिस, मल्टीपल टाइप्स ऑफ वेस्कुलाइटिस हैं, तो हमारा जो डायग्नोसिस के ऊपर जो हम फोकस कर रहे हैं, ट्रीटमेंट तो इनकी ऑलमोस्ट सबकी सेम है. वी स्टार्ट फ्रॉम द स्टेरॉइड्स टू इम्यूनोसप्रेसेंट. तो हमें लॉजिकली जो है वो जो फोकस डायग्नोसिस के ऊपर करना चाहिए या हमारा एम ट्रीटमेंट के ऊपर होना चाहिए? तो सर से ये मैं क्वेश्चन पूछना चाह रहा हूँ.
अच्छा, यार देखो, diagnose, you are right that we have to treat them medically with anti-inflammatories, yeah, immunosuppressive medication. But if these patients are not treated, they may end up with different type of complications. For example, polyarthritis nodosa है, hepatitis B के साथ उसकी correlation है. Hepatitis B के patients में you can get polyarthritis nodosa. उसमें if they are not treated early, they can get small aneurysm, they can get hemorrhages, they can come in the middle of the night, they call you that the patient is bleeding in his abdomen. Well, aneurysm has ruptured, and you go in as a vascular surgeon and treat them. And then you sort of scratch your head and say, what is going on with this patient? ये कौन है? क्यों इसे रप्चर किया? इसका एन्यूरिज्म भी छोटा सा है, फिर आप देखते हैं कि उसका बहुत सारे एन्यूरिज्म है उसमें. So it is important to know what are you are dealing with. So diagnosis is equally important. Yes, I agree with you that majority of them we have to treat them, but majority of them, we have to actually have a diagnosis so that we can, anticipate the complication. For example, Takayasu है. Takayasu में जो है वो मेजर आर्टेरियल स्टेनोसिस होती है. It can cause end organ ischemia. अगर हमें पता ही नहीं है कि उसकी डायग्नोसिस क्या है एंड उसको एंड ऑर्गन इस्कीमिया होता है, हम उसको ले गए एज ए नॉर्मल इस्कीमिया, whereas we have already said that during the process of inflammation, we should not treat these patients. We should treat them when they are in what do you call, when there's no active inflammation, because the results of these the outcomes of the surgery is much better in those patients, and the complications are much higher when the patients have inflammation. So it is diagnosis is also very important.
Yeah, thank you.
But I agree with you that majority of them are treated medically.
That is good. Actually, so we have an MCQ session and we have few resident presentation. Maybe we will do the resident presentation if we have time or in the next session. Adil has raised hand. Ji Adil, do you have any question?
Sir, it was a very good presentation. Sir, I just want to ask about the diagnosis. For diagnostic purpose, it is mandatory for biopsy. हम कहेंगे कि biopsy ही diagnostic test है, या हम बाकी तो कोई specific diagnosis नहीं है, constituent symptoms हैं या उसकी history है, weak history है, weight loss है, fever है, लेकिन जो diagnostic है वो हर के लिए biopsy ही है या उसकी किसी और पे भी हम कह सकते हैं, जितनी भी इसकी types हैं vasculitis की.
देखो, बायोप्सी, अब आर्टरी की बायोप्सी लेनी है, अब एओटाइटिस है उसको, अब एओटा की बायोप्सी कहाँ से लेंगे? बट बायोप्सी हम लेते हैं व्हेन देयर आर स्किन लीजन, एंड इट कम्स वेरी डाउन इन द एल्गोरिथम, whereas if I can show my presentation again, पता नहीं कहाँ गई है यार, ये मैं इसमें देखता हूँ. मैं ये मेरी प्रेजेंटेशन नजर आ रही है आपको?
जी जी.
I'll go back to that algorithm in the beginning. So if you look at this algorithm, biopsy is here in the end. ठीक है, उससे पहले आपने सब चीजें करके देख ली हैं, आपने हर चीज को इन्वेस्टिगेट भी कर लिया है, आपने उसके ब्लड्स भी कर लिया है, उसके एंजियोग्राफी भी कर ली है, उसके एंटीबॉडीज भी कर ली हैं, उसके बस अगर कुछ नहीं होता, then you do the biopsy, and also where you can, अगर स्किन लीजन है तो उनकी बायोप्सी होगी. अब या फिर उसका कहते हैं इस तरह जॉइंट सेल आर्थराइटिस है, you do a biopsy of the temporal artery. So this is where you can do that. Otherwise, biopsy comes in the end for that.
Okay, sir, thank you.
So we go to the next session. So
सर एक क्वेश्चन था.
जी.
हाँ डॉक्टर महाजन. सर जैसे हमने पेशेंट को ट्रीट किया वेस्कुलाइटिस के लिए, मतलब जैसे टकायासु है या जॉइंट सेल में है, तो उसमें अब जैसे आपने टकायासु का बताया कि मल्टी सेगमेंट डिजीज हो सकती है, कुछ नॉर्मल वेसल होगी कुछ नहीं. अब उसके अंदर अगर हमने कोई इंटरवेंशन, मतलब इन सेंस कि हमने ट्रीट किया पेशेंट को, पेशेंट के इन्फ्लेमेटरी मार्कर्स वगैरह नॉर्मलाइज हो गए हैं, लेकिन स्टेनोसिस स्टिल प्रेजेंट है, तो उसके लिए फिर हम मतलब सर्जिकल अप्रोच की तरफ जो जाएंगे, वो हम क्या जा सकते हैं, मतलब एंडोवेस्कुलर की तरफ जाएं?
अच्छा, मैं आपको सिनेरियो देता हूँ. सिनेरियो क्या देता हूँ मैं आपको अभी. एक्सक्यूज मी. मेरे पास मेरी पेशेंट है अभी, मैं जिसका जिक्र कर रहा था.
जी
शी इज
सर.
45-year-old Egyptian. She is diagnosed Takayasu with 50% stenosis of her left common carotid artery. That is the only vascular lesion she has at the moment. She is in remission She is taking the medication, immunosuppressive ले रही है. She is in remission, but she is completely asymptomatic. और अभी मैं आपके लास्ट वीक में वो आई हुई थी, तो उसको डिस्कशन हुआ, मैंने उसका रिपीट किया डुप्लेक्स स्कैन, और उसके बाद उसके तो शी वाज आस्किंग मी के डॉक्टर व्हाई डोंट यू जस्ट ट्रीट दिस आर्टरी नाउ. Now, my question to you all after listening to all this, a patient of 45 years old who is asymptomatic, 50% stenosis of the common carotid artery, starting all the way from its origin to the bifurcation of the common carotid artery on the left side. Should we treat this patient or not? Forget about that patient don't have Takayasus.
No.
Forget the Takayasus. Should we treat this patient or not?
Everyone
Yes,
on the chat box, what will their opinion and why? If they say yes, why? If they say no, why? Everyone should write on the chat box. We wait for the answers. This is a very important question. Shafiullah says it should be treated, yes. Mukim said no because it is asymptomatic. For stroke prevention, stroke, okay. Adil is saying no, patient is asymptomatic. And Kamran is saying no, Maz is saying no, and Mohsen is saying no. And no on surveillance. And Muhammad, she is remission and asymptomatic. And asymptomatic. Shoaib, no, not asymptomatic. But only Shafiullah is in the opinion of yes. Shafiullah, can you explain why you wanted to treat that patient?
सर ये बुक में पढ़ा था कि केराटिड बाईपास जो है वो इंडिकेटेड है अगर कॉमन केराटिड आर्टरी में स्टेनोसिस हो और प्रिवेंशन ऑफ स्ट्रोक सर एंड द बाईपास शुड कम फ्रॉम द आर्च. ये पढ़ा था सर, इस वजह से.
Which book you read and what was the rationale?
सर रदरफोर्ड में लिखा है सर.
Okay, so please share the reference with us because your colleagues don't think that this is needed, and same is true for us. If it is not symptomatic, we never treat asymptomatic patients. लेकिन अगर symptomatic stenosis है, then we treat it. But if you have some reference, do share in the group, WhatsApp group में आप share कर दें, ठीक है? And then we can have discussion.
Yeah. What my policy is that I don't treat asymptomatic patients. Yes, right. There is some evidence from I'm talking about atherosclerotic disease now. I'm not talking about Takayasu. I'll come to Takayasu in a sec. So in atherosclerotic disease, I personally avoid asymptomatic carotid artery stenosis operations because in my view, patients have no symptoms, especially if the patients are old. Yes, if the patient is young, then I give them the choice, and if the patient wants an operation, we'll do it. But I have this is my personal view. But there is evidence, but you have to do significantly more carotid arteries and arterectomies to prevent one stroke as compared to a symptomatic one. Symptomatic के अंदर मेरे ख्याल में 8-10 ऑपरेशन के अंदर आप you can excuse me, you can prevent one stroke. Asymptomatic में up to about 25 to 30 and arterectomies करेंगे तो आप prevent one stroke. So there's a huge difference between the two. So I personally, this is my policy, but people do operate on asymptomatic stenosis as well. And there is evidence for that. Obviously, उसमें इसका पे कहते हैं risk benefit you have to check with the patient. As far as the Takayasu is concerned, I think you see there is no atherosclerosis. There is no plaque which is actually causing stenosis of the artery. There is no risk of rupture of the plaque. There is no risk of ulceration of the plaque. That there is no risk of a lot of turbulence which can create emboli, which can go into the distal circulation. So in a fibrotic type of or a smooth artery, which happens in Takayasu. There is inflammation of the whole of the artery and fibrosis. It is a pan-arterial thickening and stenosis. So उसमें ल्यूमेन तो छोटा हो जाता है, मगर ल्यूमेन स्मूथ है, उसमें एम्बुलाय बनने के चांसेस बहुत कम है. यस, वो अक्लूट तो हो सकती है, but it cannot cause embolization. So a preventative operation for something which is not going to happen is something which my feeling is we shouldn't be operating on these patients unless they have symptoms.
तो शफीउल्लाह ने शेयर किया एक रदरफोर्ड का पैराग्राफ इन द ग्रुप. तो उसमें बेसिकली शफीउल्लाह, इफ यू रीड इट carefully, that line that really states that you treat the lesion when they are causing ischemic symptom, means when they become symptomatic, then bypass is an option. If you read that line, sir, मैं पढ़ता हूँ कि open vascular surgical intervention has been a mainstay for treatment of complication associated with TA. Complication. The majority of vascular lesion associated with Takayasu arthritis cause ischemic symptom if they are causing ischemic symptom and are best managed with bypass surgery. If they are. In this particular case, we are talking about an asymptomatic patient which has not caused symptoms. And common carotid bypass is typically performed for carotid prevention, stroke prevention, and is one of the most common performed procedure for ischemic disease. And they have given the reference 13. You can go explore it a little more, what they are saying. Like probably they are saying that if the patient is symptomatic or ischemic, then we have to do it up. But for asymptomatic, unlike atherosclerotic carotid artery disease, lesion of the Takayasu arthritis are longer, poorly amenable to endarterectomy, and cause symptoms through thrombosis rather than embolism. Endarterectomy in patient with Takayasu is more difficult because of so Takayasu, definitely if you have to treat them, don't go for endarterectomy, go for a bypass. But the main thing is that the indication when you have to treat it. So the consensus probably among the practicing surgeon is that if it is asymptomatic and is not causing any symptoms, we do not tend to touch them and try to treat them conservatively. But if they do cause symptoms, when you consider bypass is a good option. Yeah.
Exactly. This is exactly what I said. Because there is no endarterectomy option there. If it has become symptomatic or occludes, then you can do a bypass, but you cannot do a endarterectomy in such cases.
So we can go through some of the MCQs. Sir, we usually do. So sir, आप अगर stop sharing कर देंगे तो I can start.
Yes, I can. How do I do that? You have to tell me how to do it.
आप ऊपर जाएं सर, stop sharing लिखा हो.